it was previously implemented in 4 of the countries. So these projects, 8 countries, and only 4 use mSupply, and it was already implemented there. So we had quite a good run as far as us being able to just pull the data in. We were quite lucky in that respect. But Samoa is one of the countries of the project, and they are having mSupply rolled out next year. So there will be 5 countries that will have data for, and I think the beauty of the Pacific is at the moment that the 5 countries are using the same system, so we can pull in data something like this. Now, of course, Tupaia has the capacity to pull in data from another system, but given that the training can be, a single training tool can be used across 5 countries, or we could have bring everyone into a central country and have a training on the same system, has been really valuable so far. The hurdles to the current level of data visibility are, I think, that we still need to go through and weed out the facilities that are showing false zeros. So it might look in Tonga, for example, like a lot of facilities are really bad at managing stock, but that's not actually the case. It's just that they don't use mSupply. So I think we're still overcoming those hurdles. And the checks put in place for accuracy, we are implementing when they go out and about and they're doing using mSupply using the Tupaia Meditrack app to do this spot checks at each facility, there is a question on stock on hand for the maternal health and contraceptives items. So that will sort of be a double check when they find out if there's any stock on hand, if they've had any stock outs and the days of stock out. We should be able to go back through the data as sent through by mSupply monthly and account for that. And if they match up, then we know they're doing well. But I guess also a huge part of this is that we'd ideally like to go to these countries and provide a lot more on the ground training, especially at the facility level in mSupply. And it's always on our radar to do refresher training. It's just been really hard because, not sure if you've heard, there's a little virus going around, made it very difficult to travel. And that might be it.
All right, Erin, again, thank you for being here at this hour. If you don't mind staying a little bit longer, usually we have some time at the end for folks to ask more questions and for you to engage with the other speakers in this track. So we'd love for you to stay if you can. I am now going to set us up for the next presentation here from our friends from InSupply. They sent a video in, so I'm going to share my screen.
My name is Sadik Abdikarim. I'm working as a project officer at InSupply Health Limited, and I will be presenting to you an abstract on cStock for supply chain responsiveness and resilience in ASAL counties in Kenya. About InSupply Health, it is an health advisory firm in East Africa affiliated with JSI. Its mission is to transform lives by co-creating innovative and sustainable solutions for healthy communities. We are not your typical health advisory firm. We are a startup, fashion more like a social enterprise. Our team are entirely local and understand the context of the communities, but we also have a regional and global outlook, which allow us to collaborate with communities to introduce innovations that adapt to their needs and context. We are specialized in developing supply chain maturity strategies, building organizational capacity for supply chains, designing and implementing data-driven supply chain system, and forecasting health commodity needs. Community health volunteers play an important role in community health service delivery. They extend care and support to the communities, especially to those communities in hard-to-reach areas. They are the key drivers in achieving universal health coverage in most countries, but they face a number of challenges to perform their task. These include low literacy level, inadequate reporting tool, low capability to complete reports, inadequate access to the health services, especially in arid and semi-arid counties. And to address those challenges, InSupply Health have adopted cStock approach for the nomadic communities. It is an effective approach, and it has been piloted and scaled up in Siaya County in Kenya. Since then, it has improved the visibility of logistic data and prevent stock out at the community level in Siaya County. InSupply Health then undertook human-centered design to adapt the cStock approach for the unique challenges experienced by the CHVs in remote and hard-to-reach communities. The target communities were from the 4 ASAL counties in Kenya, which is Mandera, Samburu, Turkana, and Wajir. In Samburu and Turkana, InSupply Health is working with Amref Health Africa. In Mandera and Wajir, InSupply Health is working with Save the Children, which is also implementing the nomadic health project in that area. The supply chain responsiveness and resilience require a holistic review and substantial logistic data. And to enhance that, cStock combines 3 components. The first component is mobile technology that provide logistic data and improve communication. The second component is user-friendly dashboard that enhance end-to-end visibility, standardize the resupply process, and support performance management. The third component is impact team that strengthen the culture of data use and promote coordination at all levels in solving supply chain challenges. On methodology, InSupply Health was able to involve the voice of the end users at the center of design process. And that has been done through human-centered design in order to understand their problem and needs. InSupply Health have been always a champion of this approach that allow the key stakeholders to participate in a constructive process of identifying problems and finding solutions. To redesign the cStock with human-centered design approach, InSupply Health was able to have one-on-one interview with the key stakeholders, observe how the CHVs were performing their task in the field, do the usability test of cStock application, and then come up with 4 prototypes to further iterate and develop. And that was to redesign the manual tools, to redesign the cStock application, to design community health assistant portal that will be used to monitor the performance of community health volunteers, and finally come up with cStock USSD. The community health volunteers can use their own mobile phone and whatever technology available to them. At the end of every month, they will be able to do their reporting either through cStock application or cStock USSD. On cStock application, the data can be captured offline and submitted when there is internet access. And on cStock USSD, the community health volunteers can send their report without internet, and it is free for them. The cStock has a dashboard for decision making, and once the CHVs or community health volunteers have done their reporting, the dashboard will visualize the data so that the top management level will be able to review the key supply chain indicators and make informed decisions toward improving the supply chain performance. Some of the key supply chain indicators that can be reviewed on cStock include the monthly CHV reporting rate, the stock status, the stock out rate, emergency order, consumption rates, and the data quality. The cStock implementation was done in 2 phases. In phase 1, an intensive HCD that put all the users at the center of design process was done. And based on the HCD feedback, documentation was done, the 4 prototype was developed and evaluated, then the development of cStock was revised. And then the implementation of cStock began with impact teams at county and sub-county level in order to strengthen the culture of data use for decision making. In phase 2, the cStock was rolled out in the 4 ASAL counties using a cascade training. And in this case, in supply health was able to train the master TOT that has further rolled out the approach to the community health volunteers. During the cStock rollout, 32 members of county health management team, 60 members of sub-county health management team, 241 community health assistants, 3,527 community health volunteers were trained. Currently, in supply health is doing continuous monitoring through developmental evaluation for adaptive learning and a regular review of cStock dashboard for performance monitoring and implementation of impact teams at all levels in order to improve the supply chain performance. Some of the key lessons which were learned during the cStock rollout are acceptance of cStock by the Ministry of Health as an important system that improves the supply chain performance. The cascade training adopted by in supply health in cStock rollout has created ownership at all levels. Community health assistant and community health volunteers has found it easy to use the cStock platform. To further the cStock innovations and digitization, in supply health has collaborated with HealthInet to integrate the paper EMR technology into the cStock approach. The paper EMR will enable the community health volunteers to take the picture of paper form, and in this case, the picture of their inventory card, in which their data will be automatically digitized. The partnership is currently being piloted in Turkana County. In a nutshell, the cStock approach has enabled the CHVs to provide a real-time and actionable supply chain data, which has increased the visibility and flexibility of responsive and resilient supply chain for nomadic communities. The platform has strengthened the utilization of logistic data, and its integration with paper EMR technology will further enhance the responsiveness and resilience supply chain for the nomadic communities. Thank you for your time.
All right, so that was from our friends from In Supply Health. I wonder, because I don't see our friend Sadik's name in the list of participants, whether there's someone else from In Supply in the audience today who might be able to answer some questions. I'm hearing none. So we'll also have some time, again, this was a very short presentation, to maybe wait for someone to come in from that group to answer some questions. So we'll move ahead onto the last presentation, which is also a video. So I'm going to set us up here. This is the presentation for which we have French translation available. So If you need that, please feel free to access that through the Zoom button that says French. The next presentation comes to us from our friends from the World Food Programme and also Côte d'Ivoire government.
Welcome to this session. My name is Niels van Wassenhove. I'm part of the Regional Bureau for West and Central Africa of the World Food Programme. And I'm both delighted and honored to be with Dr. Maria-Pauline Adou from the Direction de l'Activité Pharmaceutique of the Ministry of Health of Côte d'Ivoire, and with my colleague Luis Anjos from the Supply Chain Planning Unit of WFP. So today we want to share results of an initiative that started 2 years ago, thanks to the support of the Bill and Melinda Gates Foundation. It is a collaboration between the Ministry of Health in Côte d'Ivoire and the World Food Programme to launch a supply chain control tower. So let's move directly into the topic. So first of all, a few very important principles when talking about control towers. So in WFP, we really focus on a few essential concepts. The first one is a single source of information. So there's a lot of stakeholders in the supply chain. So we need to make sure that to make decisions, we look into the same information. That information needs to be from end to end. So from the moment a product leaves the manufacturer to the moment it reaches the facility at the last mile, we need to be able to understand what is happening. So the last thing you want as a supply chain person is to have surprises, bad surprises. So we always think in terms of anticipation, so forward-looking management, being able to anticipate problems before these occur. So when you look at this image in the center of the slide, if you're sitting in that control tower, you will see a lot of things. So you will have a lot of noise as well. So you need to be able to quickly zoom into the things that really matter, and that's the exception-based management. So if we get these couple of concepts right, the control tower should bring us the visibility, which leads then to improved supply chain decision making. So I will let my colleague Luis unpack the concept for us. Over to you, Luis.
Thank you, Niels. And as you mentioned, the control tower approach is at the core of the WFP operations. In a very tangible manner, the control tower services have been key for the WFP to manage many of our large-scale operations, like in Syria, in Yemen, in South Sudan, in the last few years. So in the WFP, the control tower services are provided by a dedicated team called the Supply Chain Planning Unit that on the day-by-day is very focused on these three key pillars. The first one really focusing on bringing end-to-end visibility to our operations. So bringing all data from the different data sources together in one unified data picture, providing a 360 visibility across the supply chain and allowing us to identify potential bottlenecks that need to be addressed. The second pillar is all about anticipation. So, and really using the data to predict what may happen in the future and alert us sometime in advance, so we can have time to act. And the third one is really focused on optimization, and where we ensure we use the latest on operations research coming from universities and private sector, and we use complex mathematical models to solve some of the most complex networking problems that we face, making sure that as much as possible, we apply optimal solutions to our operations on the ground. And in the last few years, we have been challenged by several partners on the health center to apply the same type of approach to help them to better monitor and manage their supply chain. Some examples here on the slide. For example, the work that we have been developing in Central African Republic, supporting the local government and partners like Global Fund, World Vision, Croix-Rouge Française, providing visibility on the nationwide distribution of malaria, HIV, and TB medicines. And this is a project that we started 2 years ago also, and that we have shared with you in the conference last year. Another good example is the support that we are providing to WHO in Yemen to monitor the cargo flow on the different corridors. As we all know, it's a very volatile operation that requires a lot of agility to constantly switch between the corridors that are constantly opening and closing. So we are supporting WHO there to monitor very closely the cargo we are sending through Hodeidah, through Aden, through Salalah, or through Jeddah, to be sure medical cargo arrives as planned. And of course, that work that we are showcasing today, that is around the support that we are providing to the Minister of Health of Ivory Coast in the areas of end-to-end visibility and optimization, and that we are now deep diving in the coming slides. So contrary to other contexts and projects where we have set up everything from scratch, when we started the project in Ivory Coast, we quickly realized that there were already very solid foundations in place. On the process side, monthly planning meetings were already taking place for all programs. Data exchange protocols between teams were already existent. So very solid foundations. On the system side, data was already being captured systematically through its LMIS system, and even some KPIs were already being calculated and monitored. And more important than everything, on the people side, there was already the right mindset. MOH had already created a dedicated team to look to this type of issues, data issues, so the DAP team. That was a great group of people with the right mindset, a data-driven mindset, and with a team that had the right analytical skills to push this forward. So our collaboration with the team there was really focused on empowering the DAP team, I would say, this supply chain planning team in MOH, and work with them in 3 key areas where they asked our support. The first area was around creating an end-to-end picture of the data. So data was available for the different programs, but was scattered in different files. So there was the need to create one end-to-end picture, something simple and visual that could support the monthly planning meetings and put everyone on the same page in terms of the key issues that need to be addressed and when action needs to be triggered. And that was the first area of work. Second, we realized that MOH was already generating some alerts based on data, but there were hundreds of alerts being generated per month. So it was important to help the team there to find the solution and for this and find a way to prioritize them. And third, more important than everything, all the analysis that we saw that was being made by MOH was mostly focused in past performance, and here we really felt we could support with the WFP approach and bring the tools that we use on the day by day in order to predict what may happen in the future for these contexts and try to find the solutions to alert the MOH 3, 6, 9 months in advance. So they can actually have the tools to trigger actions where there's still time to act. The project started with an initial period of 6 months where working side by side with the MOH planning team, the DAP, we built an end-to-end visibility dashboard using WFP tools and a planning approach and applying it to the malaria health project. And we ensured that during that period, it was also the key source of truth being used on the monthly planning meetings. And that was the work that we did on the first 6 months. Then on the second phase, and since there were a brilliant set of people on the MOH team, we quickly passed to a phase where we focused on the knowledge transfer and helping the MOH team to expand the approach to other 2 programs. So to HIV and family planning. And basically, on the last year, from January to now, DAP is really taking the driving seat. And our WFP support is being required really when more complex analytics are required, or when a new program needs to being set up, and we are taking more this coaching role. It would be good that we deep dive a bit more onto details, and I understand how this happens in practice on the day by day. So maybe Niels, you can take us through the cycle, and then we pass the word to Dr. Adu to share a bit her experience. Over to you, Niels.
Thank you, Luis. So the first thing was really to integrate the data. Now, this really seems something trivial, but it's definitely not. So the three main sources of information are the supply plans, SAGE, which is the Central Medical Store Inventory Management System, and the ELMIS, eSigle, which is the system used to track stock at the district level and up to the facility level. So the idea was to first integrate this information, to have this end-to-end view and the single source of truth from which we could then start building different analytics to answer specific operational questions. So having the data, the visuals, and the dashboard is one thing. So once we achieved that, that didn't mean that we were able to trigger decision making. And that is why we also quickly turned to institutionalizing the procedures and the governance platforms to make sure that this information could be used by the right group of people to make decisions. And here we're showing it in a very simple 5-step type of approach. So basically, monthly production for specific programs of a set of standard analysis that everyone knows and everyone buys into. Next, use this information and these visuals to prepare and facilitate the monthly meetings. And when we say prepare, this is very important because that means that you can extract the 2 or 3 important things that will allow you to really focus in the meeting and do this exception-based type of management. Discuss in the meetings, be solution-oriented, put down a series of mitigation actions that you can start tracking and that are consensus-based. Step 4, you circulate this information to the group, but also to a broader group of people that may have a stake, and also to leadership so that you can really start driving these, the implementation of these decisions. And then obviously step 5, not an easy one, but make sure that you implement this decision made. So this 5-step cycle in monthly planning meetings supported by the data analytics allows us to go from the information to the decision making and the action and improvement. I will now pass the word to Dr. Adu, who can intervene in French. Dr. Adu, c'est à vous.
Le ministère de la Santé et de l'Hygiène publique a subi plusieurs réformes depuis quelques années qui ont permis la création d'une centrale d'achat plus autonome et plus forte, la mise en place d'une commission nationale de coordination des approvisionnements des produits de santé stratégiques, la création d'une autorité de régulation pharmaceutique et de la direction de l'activité pharmaceutique qui, elle, résulte de la fusion entre la direction de la pharmacie et du médicament et du programme national de développement de l'activité pharmaceutique. Les missions de la DAP, axées sur l'élaboration et le suivi de la mise en œuvre des plans stratégiques sur la chaîne d'approvisionnement, la coordination des approvisionnements à travers la sélection des produits, leur estimation, le suivi des plans d'approvisionnement et la gestion de stock, de la distribution des produits jusqu'au dernier kilomètre, la mise en œuvre du système d'alerte précoce afin d'éviter les ruptures et les surstocks, la collecte et l'analyse des données pour une visibilité de bout en bout des opérations relatives à l'approvisionnement des médicaments en vue de la décision, l'implémentation d'outils pour la gestion des produits à la périphérie et le renforcement des capacités des acteurs. Ces différentes fonctions de la chaîne d'approvisionnement sont mises en œuvre avec l'ensemble des parties prenantes intervenant sur cette chaîne, et cela en restant cohérent avec les priorités nationales préalablement définies, notamment la décentralisation de la nouvelle PSP qui devrait aboutir à la création de 3 nouvelles agences en plus des 2 existantes, celles d'Abidjan et de Bouaké. Le déploiement d'un outil de gestion de stock au quotidien à partir de M-Supply, l'amélioration de l'exploitation des données pour la prise de décision à tous les niveaux dans un contexte de mise en œuvre de la couverture maladie universelle et de la lutte contre la COVID. En termes d'illustration des acquis sur le projet mis en œuvre en partenariat avec le Programme alimentaire mondial, nous vous présentons ce visuel qui intègre plusieurs sources de données permettant de retracer la désignation du produit, son stock au niveau central, sa consommation mensuelle moyenne et l'information sur les péremptions probables. Il fait une projection sur les 12 mois à venir en matière d'approvisionnement et propose des actions clés de levée des goulots d'étranglement identifiés. Sur la première ligne, nous constatons que l'artésunate amodiacune adulte est en rupture au cours de la période. Il est attendu une quantité devant nous permettre d'atteindre 5 mois de stock. Le comité va s'assurer, vu la rupture, que ce produit sera prochainement réceptionné tout en mettant l'accent sur l'urgence de sa distribution dès sa réception. Il nous informe également que dans les 5 prochains mois, une rupture risquerait de survenir, nous permettant ainsi de proposer des actions de rapprochement de la commande à venir tout en surveillant les consommations du produit. À la différence de la slide précédente, qui permettait au comité de manager le stock au niveau central, ce visuel met en relief la répartition des stocks sur toute l'étendue du territoire et au niveau des établissements sanitaires où se font les dispensations aux bénéficiaires finaux. Une inégale répartition de la luméfantrine pour la cible de 0 à 3 ans est visible, avec possibilité de redistribution inter-districts sanitaires. Ces visuels sont transmis aux directions régionales pour que des redéploiements se fassent avec un feedback au niveau central. La mise en place de cette tour de contrôle avec des tableaux de bord qui facilitent la prise de décision a donné comme principaux résultats la levée des ruptures de stock, aussi bien au niveau central que périphérique, par l'avancement des commandes et le redéploiement des stocks en district. Le cas du programme national de lutte contre le paludisme, où une commande de la luméfantrine 3 à 8 ans attendue pour août sont arrivées finalement en juin 2020. Même situation que pour le détermine HIV test. Cela nous a également permis d'anticiper sur la consommation de certains produits qui étaient à risque de péremption en accentuant la sensibilisation au niveau des gros consommateurs.
Merci, Dr. Adou. So back to English. To conclude, we've made great progress and we're very happy with this collaboration and its results so far. There were a number of success factors, but also obviously challenges. So quickly to the success factors, what we learned in this journey is that it's important to quickly go and use the information and the data. So quickly take the analytics and start using them operationally. Focus on people and the competencies. Make sure that you have the basic supply chain planning and analytical skills. This is really core, and we were very fortunate to be able to work with Dr. Adou's team. So the mindset is something that's essential, a collaborative mindset throughout the supply chain to make sure that you can bring the different stakeholders around the table and have these type of conversations to solve issues. And then the last one is a bit of a pitfall in many ways. So we often rely on technology to solve our challenges, but we also realize that it's important to get your process right and to get the basic skills before you actually go on to automation. It's fine to do things manually in the beginning and not look necessarily at technology to solve our visibility and control towers issues. Now, what we still can improve is, of course, the data. The data is continuous improvement work. When we use the data, we see problems and we improve it. Decision-making processes, sometimes issues are detected. Most stakeholders, if not everyone, is aware, but that doesn't mean that we are able to actually solve the issue on the ground. So that is still something to be improved. Stakeholder buy-in and alignment, again, lots of stakeholders, very complex public health supply chains. So it's a constant effort to make sure that everyone remains engaged, that everyone is aware of what we're trying to do and is behind it 100%. And then obviously the financial resources to be able to sustain a supply chain unit, a supply chain planning unit, which is essential to manage your control tower. So to end this presentation, based on this experience, we believe that these principles of the control tower can actually be replicated in different contexts for public health and in different maturity contexts. So with this being said, I'd like to thank everyone, and we'll be happy to take any questions that you may have.
Fantastic. So I know that Niels, Louise, and Dr. Adu are here with us today and can answer any questions that the audience might have, which again, you can feel free to type that in the chat or just identify yourself and unmute yourself so we can hear you. Maybe I'll get us started while folks are thinking through their questions. You know, to Niels, Louise, and also to Dr. Adu, I was wondering, I've been hearing this theme of, you know, technology can't necessarily fix all our problems. And it seems like, you know, process and people are kind of the key factors that I've been hearing, especially when it comes to a resilient supply chain. I don't know if you had anything else to add to that point. Maybe speak to maybe some of the challenges you faced on the human resources side and maybe how you address that in your work, in your joint work together.
Thank you, Anton. So I will give my my 2 cents. Luis Anjos from Supply Chain Planning here, and maybe if Dr. Adu wants to add something, I think would be good to hear also from the Minister of Health team. As you said, and as Niels mentioned in the presentation, this is a pitfall. In a way that usually we try to solve the problems with bringing more technology, and this is something that we learned in our WFP field experience by doing mistakes and understanding really that you cannot bring very complex tools and processes to many of these contexts without actually working on the basics. And the basics, many times what people need is just really a set of simple visuals that can show in a simple way the data that they have on their complex Excel. And many times we underestimate the power of solving these basic, I would say, issues, because 80% of the problems, many times we can just solve it in a way to ensure that everyone is looking to the same set of data and is actually having the same understanding on the data itself. And that's the type of work that we did together with the MOH team. So as you can see, we are just bringing all the data from the different systems in one set of visuals that we worked with together with the DAP team headed by Miss Dr. Adu, and that we also supported to actually introduce this to the different programs with the malaria program team, with the HIV program team, and actually working on how to actually look to the data and make better decisions made on this. And here, key was actually as we repeatedly said many times during the presentation, was really the human factor of having the right people and the right mindset at the MOH level. So people that have analytical skills and that are really driven by this type of approach. I don't know, Niels or Dr. Adu, if you want to add something on this point. Over. So I guess not.
Okay. why don't we, maybe you can answer this next question, Luis, or Niels, who hopefully is also still signed on. Can you explain what technology components or platforms were used for the for your control tower model? You mentioned cStock, but was there something else that you could expound on this?
So as we mentioned, so we are ingesting information from different different systems existing at the moment in the Ivory Coast setup. So as Dr. Radu and Niels mentioned, mainly from ingesting the supply plans from the different programs. One, so really when the procurement plans and actually when the goods are arriving to country, and then putting that together with the information of the Central Medical Store, SAJ, and then with the existing LMIS. And we, at the moment, we are putting that together using a simple integration in an Excel model, and together using that together with Tableau to doing some visuals. But again, because the approach and the problem that we want to solve here is really to come up with a set of visuals and analysis that actually can support decision at the monthly meetings. And of course that now I know that the Minister of Health is taking solid steps to work on the systems integration of the different systems integration more from an infrastructure level. And we feel that the work that we are doing now can then be used, I would say, to then, after all the data is ingested in a systematic way, people already know what visuals they want to see to actually take decisions. And that's where we feel there is some added value on all the work that we are doing with MOH. I don't know, Sarah is our head engineer, if I missed something here, or if Dr. Adu, you want to add something else, over?
I know, Luis, exactly that. The process is basically combine data coming from different sources, some of them logistics systems already in place, and the Excel files information. I think Adu wants to add some information. So over to you, Dr. Adu.
Allô, bonsoir. Bonsoir à tous. Je pense que je vais intervenir en français et puis vous laisser traduire. Allô, vous m'entendez? J'ai pas de retour en fait. Je ne sais pas si mon intervention est bien perçue. Allô?
We can hear you, Dr. Adu.
Okay, thank you. D'accord. En fait, déjà, vous dire merci à cette opportunité que vous nous donnez de pouvoir partager notre expérience en la matière. Nous remercions également le Programme alimentaire mondial pour cet appui qui est très apprécié. Il faut savoir que la question de l'analyse des données n'est pas forcément quelque chose qui est assez courant dans le secteur pharmaceutique, malheureusement, surtout public. Et donc, il y a un certain nombre de données qui sont produites à partir de différents systèmes, mais il n'y a pas forcément cette forme de recoupage des données pour s'assurer de la performance du secteur pharmaceutique, de pouvoir faire cette analyse de données, s'assurer que ce sont des données de qualité qui sont produites, quelles sont les incohérences qui peuvent s'y trouver. Et donc, il faut forcément passer par cette forme d'analyse des données pour pouvoir ensuite évaluer nos performances, et en tirer les leçons et puis essayer d'avancer. Je pense que ce qui a été probablement notre force, c'est que le ministère a pu permettre qu'il y ait été mis en place une commission de coordination des approvisionnements dont nous assurons le secrétariat. Et donc, nous sommes cette plateforme-là qui réunit en gros tous les acteurs clés de la chaîne d'approvisionnement, donc pour pouvoir ensemble régler tous les risques qui existent sur les approvisionnements. Donc, on est cette plateforme qui réunit les acteurs et donc nous avons cette possibilité-là de pouvoir leur présenter les réelles performances du secteur, identifier les goulots d'étranglement et ensuite pouvoir, avec ces acteurs-là, prendre des décisions et aller les implémenter. Donc, aussi bien au niveau central que périphérique, parce que nous sommes en même temps ce lien-là entre le niveau central et périphérique. Donc, je pense que la principale force, c'est d'avoir mis en place cette unité de coordination des approvisionnements, de pouvoir en assurer le leadership justement avec l'appui apprécié des partenaires comme le PAM. Il y a d'autres partenaires qui nous appuient bien évidemment, mais on a pu vraiment pu intégrer la question de l'analyse des données et de faire la triangulation entre plusieurs systèmes. Donc, les données qui proviennent du niveau central à partir de Sage, donc du niveau périphérique et même de M-Supply qui est en cours de mise en place. Et on veut aller même au-delà, pouvoir intégrer les données cliniques qui proviennent de DHS2 pour pouvoir effectivement faire cette triangulation parce qu'aujourd'hui, on se rend compte qu'on ne peut pas, au niveau de la chaîne d'approvisionnement, évoluer sans intégrer forcément le volet clinique. Donc, il faut pouvoir s'assurer que tout ce qui est produit comme données au niveau logistique est en cohérence avec tout ce qui est fait au niveau clinique. Donc, pour nous, aujourd'hui, c'est ce réel défi-là qu'il nous faut pouvoir challenger, qu'il nous faut pouvoir relever.
Thank you, Dr. Adu. Maybe to close out this session, I was going to bring back our last presenter and also Erin to answer this question that goes, oftentimes embedding new processes and use of data doesn't follow on from digital solutions. What do you think was key in establishing lasting improvements? Maybe Erin, you can take this one first, and then we'll hear from the World Food Programme group too.
I think for us, we're probably still hoping that that they will use the data for lasting improvements. But I think that for this project in particular, the real important thing has been that UNFPA are on the ground. So despite COVID, despite other people not being able to travel to have any oversight as to questions or problems that arise. So I think two things. One is that they already use, a lot of the countries already use M-Supply, and the ones that don't, we aren't asking them to at this stage. They, it's not a whole, it doesn't represent a whole change for them. We're just getting more data available for the reproductive health team. And number two is that they've got UNFPA on the ground. So I think that if we had have done it just JSI and BES, we would have been, you know, before we knew what 2020 was going to bring, we would have been hoping to travel and implement and train. And since that hasn't been possible, the fact that UNFPA is still there, and we know that they'll coordinate the spot checks. We know that they work really closely with the reproductive health teams. We know they've got a good relationship. I think we can count on data coming in for the foreseeable future. But whether that data is used as, you know, I think the biggest thing that we've opened up here is that often if you need to get information from one department to another, you have to go and ask that department for. So reproductive health was going to pharmacy to ask stock data. That step has been cut out now. Now, of course, pharmacy aren't always going to be able to jump at that request immediately. And by the time they get the data, maybe the need has passed, or maybe the data numbers have changed. So the fact that that data is coming through monthly straight to the reproductive health people sitting there, they can see it on their computer. They don't have to go to pharmacy for that information. I think that one, the pharmacy workload is reduced, and that is a positive. And two, that they have that decision-making tool right there. So it remains to be seen if it'll be used in any meaningful way. But I think, like I said, with UNFPA sitting right there working with them, I think that there will be the right support in place for it to happen without anyone being able to travel and change processes. Thank you.
Thanks, Erin. Luis or Sarah or Dr. Adu, do you have any thoughts about that same question?
So I would give my 2 cents, and Sarah and Dr. Adu, feel free to add. I would say two key things. One, before starting very big technology projects that exhaust a lot of the energy of the different stakeholders, without actually having the end vision of what this will change on their day-to-day, is actually prove prove that this actually has a value, and not prove once, prove it systematically during, if you need to take 1 year to put that, roll it out and use it systematically for a year, even if requires more manual work or more people to actually put the data together, invest on that. Because after people actually see the value, the technology process itself actually will make sense, and the effort that people are making will make, people will have the end vision in their minds, so they are willing to put the effort to actually pass through the technology setup type of process that we all know that sometimes can be very painful. And the second is all about having a team like we have in the AP, and that is a team that actually believes that data can drive better decision making, and that they can do it with technology or in their Excel with their own tools on the day by day. And I think that makes also that MOH has the capacity then to bring solutions forward, as we believe that now Ivory Coast MOH is actually pushing for this technology to be the next step, because I think everyone already understands the value of data to make better decisions. I don't know, Dr. Adu or Sarah or Niels, if any final comments on this? Over.
Je pense que le petit commentaire que je voudrais faire en référence à une question qui a été posée, le partenariat avec le PAM a dû depuis un peu plus d'un an. Donc, on n'a pas encore atteint 2 ans. Mais bien évidemment, comme il le disait tout à l'heure, Luis, nous avons bien pris conscience de l'importance des données. Donc, ce qu'il faut savoir, c'est que tout dépendra du leadership du pays qui demandera justement cette forme d'assistance technique. Donc, si le pays a un leadership fort, c'est quelque chose qui peut prendre moins de temps, donc moins d'un an, je pense. Maintenant, à côté, il faut savoir que la Côte d'Ivoire, avec de bons fondements, donc heureusement, on n'est pas forcément parti de zéro avec tout un travail en manuel. Il y a heureusement des systèmes qui existaient qui nous déjà permettaient au niveau central de capter les données qui provenaient de la périphérique. Donc également un système aussi mis en place pour capter les données qui proviennent du niveau central. Peut-être là où on a le plus de problèmes, c'est notamment sur la question des plans d'approvisionnement qui est sûrement en cours de règlement, qui est en voie de règlement, par la mise en place aussi d'un système qui permettra de suivre les différents approvisionnements qui se feront pour les différents programmes. Donc, effectivement, il y a eu des fondements qui ont permis la réussite de ce projet-là, et ce sont des prérequis qui peuvent être indispensables. Sinon, faire le traitement de données de façon très manuelle peut être fastidieux, et donc, finalement, décourager les acteurs. Donc, c'est de pouvoir s'assurer qu'on part sur de bons fondements, mais bien évidemment, on peut très bien, si on a un système manuel mis en place, commencer par un programme et ensuite évoluer vers l'intégration d'autres programmes. Donc, aller sur la base du programme qui rencontre le plus de difficultés et puis intégrer au fur et à mesure. Merci.
Thank you. With that, I am going to close the session a few minutes early just because we didn't get a representation from InSupply Health, our second presenter today. I want to thank everyone for coming to track 6 of day 2. I just sent out a link to the AirMeet networking site that we're using to meet people who are also in the conference. Please feel free to click on that and attend that networking session. And to all the presenters today for track 6, thank you so much for being here and for sending in your work to be presented during this conference. We really appreciate it. To everyone else, please have a good day. Thank you.
Sorry, I had a network connection.
Oh, Sadik, yes. I'm sorry we missed you.
I had a network connection, so I wasn't able to join, and I'm really sorry.
Oh, don't apologize. And, this is why we were encouraging people to send video. So, we were able to play your presentation and people heard it. I encourage you to go to the AirMeet networking session so people can find you and actually ask you some questions too.
Oh, okay, please. Okay.
We'll meet you there. Thank you, Sadik. And thank you everyone for coming.
Okay.